Good morning. I think we'll get started. Welcome to Grand Rounds. This is our annual AHA session where we highlight some of the work we're going to be presenting at the upcoming conference. We have another strong presence this year. We have 27 posters or presentations at the conference. We're involved in 39 different sessions in some way, shape, or form. So should be a good meeting. And we've got 5 presentations this morning, so let's get started. Up first is Joe Jensen. Joe is a resident that I've been working with for a couple of years now on various projects, and he's got a project today looking at statin use throughout Alina, which I think is interesting. Joe went to med school at the university here, took a year off kind of in between med school to do some entrepreneurial work. He's part of 2 med tech companies that he's starting up, and now he's in his 3rd year of residency at Abbott here with plans to do a chief year and then apply to cardiology fellowship. So, Joe?
Okay, thanks Mike for the introduction. As many of you know, next week at the American Heart Association conference there will be new cholesterol guidelines released, and I had the opportunity to work with Dr. Miedema, Dr. Frazier, and others to investigate statin eligibility and prevalence of statin prescriptions according to the current 2013 guidelines in a large multi-center healthcare system here at Alina. To start, I think it's important to go back in time to 2001 and look at the Adult Treatment Panel 3 guidelines. I borrowed these slides from the vascular biology group at the University of Florida because I think it adequately transported us back to 2001 based on the font and colors, etc. But as you can see here, after about 9 to 12 hours of a fast, a lipid panel was taken and categorized, as you can see here. Next step was to assess risk factors associated with high cholesterol, and those included age, smoking, hypertension, low HDL, and family history. Now, if anybody had 2 of these risk factors, they were automatically placed in a high-risk category. But if that was not the case, we'd proceed to the Framingham score, which you can see here is basically a further breakdown of the risk factors that assigned a point total, which then placed women and men on a curve with a 10-year CHD risk percentage that was given. So taking that risk factor and the risk category here, it's stratified according to the risks that you see here on the left, greater than 20%, less than 20%, and less than 10%. Then you'll notice here that there's actually an LDL goal here. And if above goal, the first step was to initiate TLC. And to my surprise, that wasn't tender love and care, but actually therapeutic lifestyle changes. And honestly, I don't know if there's that much of a difference. But the next step would be to consider drug therapy based on the right-hand column here. So fast forward to 2013 in the way we currently practice today, gone were the LDL targets, and instead there were 4 groups identified to benefit from statins. First, ASCVD and anyone with an LDL greater than 190 were recommended a high-potency statin, while these 2 groups, those with diabetes and those with a 10-year risk of greater than 7.5% based on the pooled cohorts equation, were recommended a moderate intensity statin. You can see we're all familiar with the pooled cohorts equation, and now since it's 2013, we can do stuff like this on our phones. So our investigation was a cross-sectional analysis with electronic health record data from Alina, and it took place in the years of 2013 and 2017, and we examined all outpatient visits with patients between the ages of 40 to 79 with enough data to assess for statin eligibility. Here are baseline characteristics. As you can see, between 2013 and 2017, the population didn't change significantly. The mean age was around 58 years old. It was an equal balance of men and women. And then you can see the risk factors outlined below. And when we compared the years 2013 and 2017, we actually didn't see much of a change in statin prevalence between the 2 groups. If you look at the x-axis down here, here are the 4 main categories for statin use. Going from left to right, we have clinical ASCVD, LDL greater than 190, diabetes, and ASCVD risk greater than 7.5%. And then this column here is this total statin eligible population, which ended up being about 50% of the total population was statin eligible. But as you can see here, only roughly 60% of the people were receiving statin prescriptions. And as you can also see in this column, we clearly do the worst with anyone in the ASCVD risk category greater than 7.5%. Now when looking at high potency statins, the data unfortunately is even a little bit worse. As you look at high-potency statin indication for clinical ASCVD, in 2013, we prescribed high-potency statins to less than 40% of people. Now, this is somewhat of a success story, as by 2017, we were near 50%, but still only 50% of patients with clinical ASCVD were receiving high-potency statin therapy. And as far as the indication for LDL greater than 190, both years, 2013 and 2017, we're only receiving about 20% of high-potency statin. We also looked at the breakdown between men and women, and the dark blue is those receiving statin, and the light blue is those not receiving statin. You can see a difference between men and women, that more eligible men were receiving statin as compared to women. And while the prevalence of statin use increased in men about 3% from 2013 to 2017, it actually decreased in women by about 0.5%. What does the other data say? Well, the JAMA Cardiology investigation looked at the trends in statin prescriptions between the years 2002 and 2013. And as you can see here in the graphs on the right, gradually increased over that time, both for any statin here in the darker color. Sorry, it's a little bit hard to see. But in the lighter color down here is high-potency statin. So this is ASCVD here, and as you can see at the end of 2013, only 30% of those with ASCVD were receiving a high-potency statin. This was thought to be due to a number of reasons. One, the statin data became stronger over that time period, and two, they became more affordable. And this is a graph showing the spending of the brand versus the generic statin. And another abstract investigation actually looked at the years 2013, 2017, and while we did see a rise of statin use from 2002 to 2013, it generally plateaued at that point, which is similar to what we saw in our investigation. The question is, why does this happen? And why does it take guidelines so long to be implemented if they're implemented at all? So it turns out, I thought maybe there would be a few papers on this topic investigating implementation of clinical practice guidelines, but in fact it's an entire field of research that is far beyond the scope of this talk due to its complexity. But I wanted to give a couple examples here, and this was from 2017, an ACC and an AHA special report on clinical practice guideline implementation strategies. So they identified 4 ways to help with this implementation: reminders, educational outreach visits, audit and feedback, and provider incentives. And through a systematic review, they realized that only audit and feedback and educational outreach visits were worth time and effort. Our critical care colleague also investigated this highly complex problem in 2013, and to start, they borrowed models, 13 different models from various disciplines, including medicine, rural sociology, psychology, human factors and systems engineering, organization management, marketing, and health education. And they came up with this simple, easy-to-follow graph showing the influence of system characteristics, provider characteristics, guideline characteristics, all playing a role in feeding back onto implementation characteristics. So this is what they call the interdisciplinary conceptual framework of clinicians' compliance with evidence-based guidelines. My takeaway is that it's complicated. So in the end, we found in a large Midwestern health system the prevalence of statin prescriptions minimally changed from the years of 2013 to 2017. We found that men were more likely than women to be eligible for a statin medication and also to be prescribed a statin medication. And finally, further efforts are needed to improve compliance with these guidelines, especially in light of the new 2018 guidelines coming out next week. Thank you.
Thanks, Joe. Very interesting and humbling data. Any questions? Gotcha.
Do you have any information on calcium scoring and how that might change? There may be various factors.
Right. Not specifically for the Alina database. I mean, we potentially could link and try and figure that out. But yeah, I think the reasons are probably multiple. If we look at that now, 2% of people that don't have a statin now listed. So many of them might have statin intolerance that's not listed, but in general, that doesn't seem to be the major driver. It's probably just inertia.
All right, so I'd like to introduce Peter Tajti. Peter is from the University of Szeged. He's been working with us for almost 2 years now. He's finishing in next month. He's been very productive. He's just taken the PubMed. He's got 25 papers, but hopefully another 10 or 15 in the next month or 2. And he's going to talk about the presentation from the Progress CTO Registry. Peter.
Thank you very much. Thank you very much for the introduction and also for giving me the option to present an insight from the Progress CTO registry on behalf of the Progress CTO investigators. I would like to speak about an overall study summary first, and secondly, I would like to present the contemporary results of the retrograde approach for CTO interventions. Progress CTO is a multi-center international registry that is enrolling from 41 sites, mostly from the United States, but also from Europe and Russia. To date, over 4,600 patients has been enrolled. The hybrid algorithm is a key concept for CTO PCI that has been introduced in 2012 by various experienced city operators, recommending an initial crossing strategy based upon angiographic characteristics and also recommending frequent changes in crossing strategy to facilitate lesion crossing. In our current inside of the Progress CTO registry, almost 3,600 patients have been enrolled, and the overall success rate was 87%. Patients with technical success were younger and less likely to have various comorbidities, and also less likely to have history of MI, congestive heart failure, prior PCI, or prior bypass surgery. On the other hand, lesions that were not crossed successfully tend to be longer and more complex, to have more complex anatomy. And as the evidence of it, the GCTO score, Progress CTO score, and Progress CTO complication scores were significantly higher in the technically failed group. Initial crossing strategy ranged between 53% and 60% only. However, using multiple approaches, an 87% overall technical success has been achieved. Failed procedures were significantly longer, required more contrast volume, fluoroscopy time, and radiation. Technical success was achieved in approximately 8 out of 10 patients, even in the more complex lesions. However, the complex lesions required more frequent use of the retrograde approach. Also, in hospital major adverse cardiac event was significantly higher with the retrograde approach, mostly driven by in-hospital death, acute MI, and also perforation was significantly higher with this technique. This graph shows that as lesion complexity increases, the chance for having procedural complication also increases. That can mostly be attributed to the retrograde approach. As my second poster, I will present the contemporary outcomes of using the retrograde technique for CTO PCI that requires a few additional steps compared to the antegrade only approach, which means crossing the guide wire to the distal cap of the occlusion and also delivering the microcatheter and then crossing the lesion from the distal cap and finishing the procedure with stenting and as a baseline, basic angioplasty. So the retrograde approach is associated with more complex coronary anatomy, with more longer lesion length, and also higher prevalence of proximal cap ambiguity. More likely to have distal caput bifurcation, although less likely to have a good distal landing zone that is, can be important for antegrade only techniques. GCTO score, Progress CTO score, and Progress CTO complication scores were significantly higher in the retrograde group. An important part of studying the angiogram before retrograde CTO PCI is analyzing the collateral channels. That is an important part compared to the antegrade only techniques. Interventionally amenable collaterals were present in the retrograde approach, at least 4 out of 5 patients, and were most likely to be filling from the contralateral artery. The baseline procedural outcomes, such as procedure time, contrast volume, and radiation, was significantly higher with the retrograde approach, as we expected. Although, as I mentioned previously, use of the retrograde approach is much more needed in complex lesions. The most commonly used collateral channel was the septal collaterals, followed by the epicardial, saphenous vein graft, and left internal mammary artery graft. The most common crossing technique was the reverse card technique, which is a combination of antegrade and retrograde dissection creation that is commonly used in CTO PCI. And the second most common was true-to-true lumen crossing. The retrograde approach was associated with higher in-hospital major adverse cardiac events, although other procedural complications were also higher in this patient subgroup. Vascular access complications were significantly higher, as well as the donor artery complications, such as thrombosis of the donor vessel or dissection of the donor vessel. And also bleeding was significantly higher in this patient subgroup. In conclusion, I would like to summarize that technical success can be achieved in 9 out of 10 patients undergoing CTO PCI, and frequent changes in crossing strategy can facilitate lesion crossing even in highly complex lesions. Overall, in-hospital complications occur in approximately 3% of CTO PCI, although the retrograde approach is associated with higher complication risk even in experienced hands. Thank you very much for your attention.
Thank you. Thank you, Peter. Any questions? No, it's a technical topic, so for many of you it might be a little too technical, but need to hear it anyway. Yes, David.
Were they both posters?
Yes.
2 posters?
Yes.
Okay. Yeah, I mean, I guess one comment would be that just there's a lot of data there to point out, and if there's anything you can do to highlight within that data what your major points are, it kind of helps draw the eye to what you're trying to emphasize. Otherwise, it's a lot of splash of data.
Thank you.
Perfect.
Yeah, Mike. Sort out the high-risk patient from the high-risk procedure, because these patients that are requiring retrograde approaches are seem to be higher-risk patients. It's hard to know if the approach is the patient.
Sure. So the question I guess for the audience on the is it the patient or the lesions being the high risk that cause it? I don't know if you have an answer to this.
Well, so as you may know,
I think it's both. I mean, it's both. I mean, it's hard to break it down, and also part of the complexity here is that it's not always the retrograde approach that's causing the complication. There's another study saying that actually in the retrograde group, many of the complications were antegrade. And that part, we don't have granularity enough to look at it, but that's an evolving concept. So, but that's a great point. All right, perfect. Thank you, Peter.
Thank you.
Great job. And then we'll move on to Iosif Xenogiannis. Iosif is from the University of Athens and at the hospital in Greece. So you've noticed a similarity in accent. He's, what accent you should say? He's done a phenomenal, he's been here for almost 6 months now, done a phenomenal work on Progress CTO together with Peter, and he's also a candidate for PhD in Greece, and we're very excited to have him work on this as well as the ASAP vein graft study, which we hope that you're all going to enroll. That's a study on vein grafts that we need to look at PCSK9 inhibitors work. Iosif.
So good morning. It's a pleasure for me to present you the outcomes of our study. So the presence of CTO, chronic total occlusion, in patients with non-coronary artery disease is a common finding. And we can see that about 1 out of 3 patients with coronary artery disease have at least one CTO lesion. CTO interventions usually require high radiation and contrast dose. And because of this reason, whether PCI of non-CTO lesions should be performed at the same procedure remains controversial. So we sought to evaluate the outcomes of combined CTO and non-CTO PCI compared with CTO PCI only using data from the Progress CTO registry. In general, CTO PCI technical success for experienced operator is between 86 to 90%, while the overall in-hospital major adverse cardiac events rate is between 0.5 and 7%. These rates are for experienced operators, while it is estimated that CTO PCI technical success among less experienced operators ranges between 60 to 70%. So we'll briefly see the definitions that we used for our study. CTO was defined as a coronary lesion with TIMI grade 0 flow of at least 3 months duration. Technical success was the achievement of less than 30% residual diameter stenosis after PCI and restoration of TIMI grade flow 3. Procedural success was the achievement of technical success without any in-hospital MACE, and in-hospital MACE was any of the following, the presence of any of the following: death, myocardial infarction, recurrent symptoms requiring urgent repeated target vessel revascularization, stroke, and finally tamponade requiring pericardiocentesis or surgery. You have already seen this slide, I guess. So this is these are the centers that participate in the Progress CTO registry. 21 centers, mostly from the States, but also, as you can see, Russian Federation, Europe, Canada, and Lebanon, Asia. So for our analysis, we used the data from 3,598 CTO PCIs in 3,534 patients, and in 23% of our cases, a non-CTO PCI took place in combination with CTO PCI, while in 87% of the cases, CTO PCI was attempted. So we can see in this table the clinical characteristics of our patients. So patients that were belonging in the CTO plus non-CTO PCI group were almost 1 year older. It was less common to be current smokers, and also they had slightly lower left ventricular ejection fraction, as you can see, 49 versus 15%. So also more often they presented with an active coronary syndrome, 31% versus 23%, while stable angina was the most common symptom between the two groups. Okay. In this slide, we can see the distribution of the lesions, and for CTO lesions, the most common target vessel was right coronary artery with 56%, while on the other hand, for non-CTO lesions, the most common target vessel was LAD with 31%. In this slide, we can see the geographic findings of our study. So JCTO score and Progress CTO scores, which are dedicated CTO scores that allow us to estimate the complexity of the lesion, were slightly higher for the non-CTO PCI groups. And we can see specific for JCTO score, 2.33 versus 2.44. So these numbers are associated with difficult lesions to deal with. And also we can see here the Progress CTO complication score. That is a score which enables us to estimate the risk for in-hospital MACE, and it was similar between the two groups. Regarding technical characteristics, undergrade wire escalation was the most common crossing strategy used, and also the most common successful crossing strategy, and this is the case for both groups. However, undergrade wire escalation was more often the final crossing strategy for the CTO plus non-CTO PCI group compared with exclusively CTO PCI group, while undergrade dissection reentry and retrograde approach were more often the final crossing strategy for the PCI, for the exclusively CTO PCI group. 18 versus 17 and 24 versus 29. Okay. So technical and procedural success rates were similar between the two groups, and asked was the MACE rate for technical success. Sorry, you can see here the numbers. 88% versus 87, for procedural success 86 versus 85, and for MACE 3.4 versus 2.7 for non-CTO plus CTO PCI. Compared with exclusively CTO PCI, respectively. P-values, you can see that all the p-values were over 0.05, That means that the difference was not significant. As it was expected, contrast volume that was used was higher for the non-CTO plus CTO PCI group, as it was the patient thermal radiation dose. And also procedural time was almost 15 minutes longer for the non-CTO plus CTO PCI group. Our study had some limitations. It was an observational retrospective study with no core lab analysis. And also the procedures were performed in high volume centers by experienced operators, and maybe the results are not representative for less experienced operators. So in order to conclude, attempting a non-CTO PCI in addition to a CTO PCI during the same procedure is a safe and effective strategy. But due to the high contrast volume and the high patient air kerma dose, close monitoring is suggested in order to keep our patients safe. Thank you very much.
Great, thank you, Peter, again. Iosif, any questions from the audience?
I think I'm thinking about
patient selection, and I would be thinking about looking at what centers are doing this, and if there is a clustering of operators that are doing these non-CTO PCIs. I suspect that you're going to find 3 or 4 or 5 people within the registry that are the ones that do these procedures, and perhaps you want to put that in the slides. You know, what are the characteristics of the operators and centers that are tackling these lesions at the time of a CTO PCI, because that may be informative.
Yeah, thank you for your suggestion, Dr. Garcia. The truth is that I haven't searched it, so I'm not really aware if there was a group of operators that like to go on with non-CTO PCI, but maybe it will be interesting to investigate it. So thank you.
Thanks. Well done. How many of these patients came in, that were set up like we schedule CTOs versus you just happened to stumble upon the CTO while you were revascularizing them for a non-STEMI? I mean, do you have any sense of the difference between?
Yeah, exactly. We can go back at this slide. So the PCI took place as an ad hoc intervention in 90% of the cases versus 11% of the cases. So most of these acute coronary events were unstable angina, not STEMI or non-STEMI. And as you can see, it was more often in the CTO plus non-CTO PCI group.
So sort of different from our practice.
and you're right. We don't want to do a whole CTO PCI. I mean that's a high number. 12, 13%, that's a high number. And there are some centers that do like 50% of all. That's crazy. But it happens. So just have that into consideration. You should not do a whole PCI for everything.
Yeah, I think that the goal is to take your time and schedule nicely your plan for the operation.
Is it any more than rare that you end up having to do angioplasty because you've injured a different vessel that you're using for access to the CTO? And maybe that's part of it.
I can answer this. So about 2% is the donor vessel injury. So that's the ones you actually mess up the vessel and you have to do something. And there are some cases in which you want to go retrograde and there's a lesion in the donor vessel and you don't want to go through that until you fix the lesion. So but this is the minority. I mean, it doesn't go up to this 18%. We'd say, 2% for the donor vessel injury and maybe, 3-4% for the other one. But absolutely right. Great. Thank you very much.
Great. Our final talk will be by Grace Johnson. Grace just graduated from Carleton College with a degree in biochemistry and English, and she worked with us the summer before last on some of our stem cells projects in the Optimus Clinic, and she's currently a scribe for an ophthalmology practice right now while she's applying to medical school. And unfortunately, she has an interview the day of her presentation here, so so Grace, take it away.
Great. Thank you, Dr. Travers, for the introduction, and thank you all for being here today. This morning I'm going to talk about stem cell therapy as a treatment for refractory angina and its potential implications for healthcare expenditures. So just to give you a little bit of background here, the population that our study was interested in was patients who are experiencing persistent chest pain despite being on optimal medical management. And many of these patients are not very good candidates for further revascularization procedures, so they have pretty limited treatment options. And in recent years, researchers have been looking into stem cell therapy as a promising alternative. And stem cells have shown promise in treating heart disease, both in preclinical models and in early clinical models. So this study focused on CD34 positive stem cells. And CD34 positive just refers to the biomarker that was originally used to identify endothelial progenitor cells. So these are cells that can promote angiogenesis. And this past June, a meta-analysis was published of 3 clinical trials that were looking at CD34 positive stem cell injections. So patients either received injections of stem cell or placebo, and then they were followed for a year or so afterwards. And these were randomized, double-blinded studies that some of our investigators here were involved in, including Dr. Travers. And unfortunately, the phase 3 clinical trial was terminated early by its sponsor, solely due to financial considerations. But the actual early results looked pretty promising. So this meta-analysis pooled the results from all 3 clinical trials, phase 1, phase 2, phase 3, for a total of 187 treatment patients, 89 placebo patients. And they found that the treatment group demonstrated significant improvement in exercise time after 1 year from injection. There was also a reduction in angina frequency that was not statistically significant, but still noteworthy, and then a significant decrease in all-cause mortality. So here are some figures from that paper. On the left, TEP stands for total exercise time, and this is over the first 12 months from baseline. You see red is treatment, blue is placebo. On the right, this is the angina frequency over 12 months for the treatment group. And then here we have Kaplan-Meier analyses over 24 months for both mortality and major adverse cardiac events. Again, blue is placebo, red is treatment. So it seems like patients did pretty well after these injections, but what we wanted to look at was the before and after picture. So we wanted to see whether patients experienced a reduction in cardiac events in the 12 months after injection compared to the 12 months before injection. And we wanted to see, well, if there is a reduction in events, how does this map on to cost savings? So we conducted a retrospective chart review of 58 patients at Abbott Northwestern who participated in one of these 3 clinical trials. And we determined healthcare expenditures using average patient costs for hospital admissions and emergency department visits here at Abbott Northwestern. So this is a tabulation of all of the cardiac events experienced by our treatment group 12 months before injection, 12 months after injection. And you see that there's a significant decrease in events following injection from about 1.5 per patient to 0.6. CP just stands for chest pain here. However, we also see a significant reduction in events in our placebo group, which suggests that there is a significant placebo effect at work here. And it's kind of hard to assess, how much of that original reduction was due to the stem cells, how much of it was just due to patients feeling like they had something going for them. But for this analysis, we were interested in the major adverse cardiac events. So here we define that as CABG, as patients who were admitted with chest pain ended up having stents put in, or patients who had non-STEMIs that had stents put in. And here we still see a significant reduction in events in our treatment group. It's hard to make meaningful comparisons with our placebo group here simply because the numbers are so small. The population of our placebo patients just seemed overall healthier. But this is just a representation of the major events experienced by our treatment group So the dark red is 12 months before injection, light red 12 months after injection, and you see a pretty dramatic decrease. So these major events were what we used to conduct our cost analysis here. And you see a pretty substantial reduction in cost following injection. So this turns out to be about a 75% cost savings for our treatment group versus a 50% cost savings in the placebo group. So all in all, it's hard to say how much of the reduction in events was due to the stem cells injections themselves, how much of it was driven by placebo effect. But the results do look sort of promising, especially when we consider the major cardiac events. And this is where the cost analysis and the cost savings really comes into play. So we felt this would warrant further investigation with a larger data pool, more placebo patients, to see how this really plays out, and also to extend our analysis to different hospitals to see whether different cost savings and healthcare expenditures vary from facility to facility. This is the original meta-analysis that I referenced at the beginning in case you're interested in learning more about these trials. Thank you.
All right. Thanks a lot, Grace. Any questions? Manos?
Thank you. Congratulations. That was an excellent study. And I must say, I've seen a few patients lately which this resonates very well. The question is, even if it's a placebo effect, if the patients are doing better, I know it's not, we have this thing where the patients do remarkably better. Makes you wonder, how do you, it's such a strong placebo effect probably, how it's very hard to decipher, right? And the numbers you need are very high. So do you think there will going to be a study like this addressing this question with the placebo arm?
Well, I think what's taken so long to show that this therapy is effective is this placebo effect. I mean, if you look at the exercise times angina, I mean, it's dramatic. And so to overcome the placebo effect, I think speaks to probably the potency of the therapy. But again, in your first sentence is like, does it matter? I mean, these costs go way down. So I think the placebo effect is strong, and patients, even if they got placebo, if they're having less admissions for chest pain and less PCIs and less coronary angiograms and ER visits, that's beneficial as well.
But we can do better and do something.
Satya.
From a contemporary clinical trial, or seems like the expenses before they were involved were much higher. And the patients that, if you look at 9,000 or 50,000 here,
right.
Before the injection, it looks like they're different patients, but few of the treatment they cost before they were in the trial. $9,000 is 28 times.
Right. Well, I think it's just the that's not per event. That's the total. Sorry, that's per event. Some of these patients had more than one event, and this, I think that the 25% of the original cost is just due to the the reduction in these events. I'm not sure if I'm following your question though.
I would assume that the cost before the injection, the one we're showing there for both groups, that is a reflection of how sick these patients are before they get into the trial.
Right.
And it seems based on that number that one group is more research. The contemporary cohort of patients should be placebo, or this is from another trial.
No, these were all three. I mean, these were all three trials that we were part of as far as phase 1 through phase 3. They're all pretty. They were all run pretty much the same way with similar dose of cells. But it is there is a big discrepancy between the treatment group and the placebo group as far as events. And I can't really explain that, which would be important to look at the other institutions to see. Fortunately, most of the institutions were much smaller as far as the numbers. We were the leading enroller in every phase of that study for this. So I think our hope is we'll be meeting in American Heart that Baxter has given up the rights. This is all Douglas Sordo's work going back 15 to 20 years when he started working in Jeff Bisner's lab in Boston. And he's now with Caladrius, and they are hopefully, meeting with the FDA to hopefully just get approval for this therapy, because this therapy is actually approved in like the Netherlands based on much smaller number of patients. So the hope is, or the FDA will say, you still have to do a few more phase studies just to complete the phase 3 study, because even the phase 3 study, which is cafe, was still positive. I mean, the consistency throughout all 3 of these trials is really fairly remarkable. So that's why I think there is a true, treatment effect with this. All right. Thanks, everyone, for coming, and thanks to our presenters. They did a great job.